The Healthcare Labyrinth Podcast is back for another episode. Join Marc S. Ryan, a veteran health plan and health technology executive, as he explores the world of healthcare.
Welcome, everyone, to this edition of the Healthcare Labyrinth Podcast. My name is Marc Ryan. It's a pleasure to be hosting the podcast, and thanks to everyone for listening in. Today, we're going to switch it up a tiny bit while we're still talking about the mundanities of Medicare Advantage and health insurance and things like that. We're going to try and tie it back to the upcoming election. I don't love to sort of take sides in this podcast, but we're going to talk a little bit about the potential for Democrats to be a victim of an October surprise of their own making. For those involved in politics, candidates and parties fear what is known as the October surprise, a scandal or national or world or state event that threatens to upend candidacies in partisan control of federal and state bodies. These events can be planned, for example, by opponents. They dig up some dirt on an opponent and release it right before the election. Or unplanned, for example, a terrorist attack, a world event, a war, things like that could also occur in October, and that could upset an election outcome. With the election very close right now, especially with the change at the top of the Democratic ticket, the race is still very close. When President Biden was still in the race with his lagging performance, Trump appeared to be opening a big, huge gap in swing states and in the popular vote. But now with Vice President Kamala Harris at the top of the Democratic ticket, this is really coming very close. President Trump is barely ahead in the popular vote. Kamala Harris could go ahead shortly. We don't know. But we do believe that this is going to be a close election, not so much because of the popular vote, because as many know, the presidential election is decided by the Electoral College. For the most part, all states but two award their number of electoral college votes to the person that wins in that state. So somebody could lose the popular vote and win the presidency in the electoral college, or vice versa. And so this election, again, is going to probably come down to a set of swing states where whoever takes it will probably end up having the 270 electoral votes needed to become the next president of the United States, and that's why this race is still pretty tight. But again, back to the issue of an October surprise, my guess is that the Democrats have forgotten about a potential October surprise that they themselves may have created, and that certainly could impact the electoral outcome. As we go a little deeper into this, I'll tell you why I think there could be a October surprise, and why maybe the Democrats are actually sort of getting an inkling of the problem and trying to pass something administratively to deal with the fallout. So anyway, before we get to the October surprise itself, we sort of need to set this up. Again, we'll be taking a couple breaks here, but to set up this podcast about the October surprise potential for Democrats, we need to talk a little bit about how does a Medicare beneficiary get their Part D benefits, and also about the Medicare enrollment season. And so let's start out with, how does a Medicare beneficiary get Part D benefits? Well, as we know, there are two ways for seniors and those with qualified disabilities to receive Medicare Part D retail drug benefits. Individuals that are enrolled in the traditional Medicare fee-for-service program, where they get all of their medical benefits, and some enrolled in a Medicare Advantage plan that offers Part C coverage only, get their Part D coverage through what's known as a standalone Part D PDP plan. These are private plans that furnish retail drug benefits to either a fee-for-service enrollee or a Medicare Advantage enrollee if he's in a Part C only plan. There are about 23 million in fee-for-service and about 2.8 million or so in Medicare Advantage that are in Part C coverage only. Well, if individuals are enrolled in an MA plan, the vast majority of them have what's known as a Medicare Advantage Part D plan, where their medical and their retail drug benefits are combined into one plan. So they obtain the retail drug benefit from that same private MA plan that is providing their medical coverage. There are about 31.3 million in MAPDs today. So most of our issue really surrounds what's going to happen to premiums in this Part D drug benefit. But in essence, we have a lot of individuals impacted by this. We have about 31 million people that would be impacted by fallout with Part D coverage in MA, along with some other things I'll tell you about. And then we have about 23 million people and another 2.8 that are impacted because they're enrolled in standalone Part D PDP plans. Next, we're going to tell you a little bit about the Medicare enrollment season, and this happens to be in roughly October, November, and December. So each October, the enrollment season begins for Medicare Advantage and Part D plans. So your PDP enrollees can change their plans then, as well as your Medicare Advantage enrollees. In the MA world, enrollment is fully voluntary for individual policies. In the standalone Part D PDP world, most is voluntary, but there is a subset of individuals that are auto-assigned into PDP plans if they have what's known as the low-income subsidy. But for the most part, those PDP plans are pretty much voluntary enrollment as well. The number of Americans going through this enrollment process is enormous. There's about 34 million people today in MA and will have to choose to stay in their current plan or change it. And again, about 23 million people are in the traditional fee-for-service program and rely on the standalone PDPs for the retail drug coverage, along with those 2.8 million in MA with only Part C coverage as well. These folks as well, those enrolled in fee-for-service and in the MA Part C only plans, will have to choose to stay or change their PDP in that window, much as the Medicare Advantage enrollees have to as well. Plan changes and premiums are announced October 1st for the 2025 calendar year on the Medicare Plan Finder, and the window to keep or change plans goes from October 15th, so you get to look at plans October 1st to October 15th, and then from October 15th to December 7th, you get to make your plan changes. Now, Election Day is November 5th. It's just 3 weeks after the enrollment period begins, and about a month after, all of these plan changes will be coming out for MA and standalone PDPs. So that's where we get a little closer to our October surprise here. And I really feel like Democrats should fear the potential fallout and the media attention around major changes in both MA and PDP, especially changes in Part D that will be driving up premiums. So with that, we'll take our first break. And after our break, we'll come back with more on the Medicare Advantage October surprise.
The Healthcare Labyrinth is no ordinary website. It features news and commentary from one of the nation's leading healthcare policy and technology experts. Marc Ryan combs the internet for the latest healthcare news and publishes a news feed each weekday with summations and Marc's insights. Twice a week, Marc publishes a blog to go deep into a current issue. And of course, Marc hosts a podcast each week to delve even further. All of this is available at healthcarelabyrinth.com. Visit each day for the latest happenings in healthcare. As well, learn more about Marc's book, The Healthcare Labyrinth, at the website. That's healthcarelabyrinth.com, your go-to source for healthcare news.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. Again, my name's Marc Ryan, and it's a pleasure to be hosting, and thanks for listening in. So we just sort of gave you a little feel about the enrollment season and how people access Part D benefits. I'm now going to get into a little more on the Medicare Advantage portion of the October surprise that I think could hit Democrats. So on the MA front, there have been numerous changes that have been put in place by the Centers for Medicare and Medicaid Services over the past couple of years. And I'm going to review a couple of those with you because this will have major impact on the benefits and premiums and cost sharing that will be in MA plans for 2025. Rates for calendar year 2024 and for calendar year 2025 were both negative due to the introduction of a new risk adjustment formula that takes about 7% out of the rate structure over 3 years. STAR performance is lower due to some major changes introduced in the STAR program as well, which also takes money away from plans. The lower your STAR score, the less money you get to keep in the rate structure for added benefits. There's also been major new regulatory changes, such as prior authorization restrictions, that make it much more difficult to save on medical expense. So the STAR performance and the rates impact the revenue side, and these prior authorization and other regulatory changes are adding to expenses. But to layer one more major cost on for Medicare Advantage, and I'll tell you how this impacts standalone PDPs as well, but the Inflation Reduction Act's Part D changes add considerably as well to plan expenses and costs by transferring liabilities from the government and beneficiary out-of-pocket costs, again, to the plans. We will talk a little deeper on that after one of our breaks, but I want to now sort of go into some of the MA changes that will be out there. So all of these things on the expense side and on the revenue side are making it very difficult for MA plans in 25. And so we will see benefit cuts and things like that. In addition, I would note that plans have seen a return of normal utilization post-COVID pandemic and more robust inflation as well in the healthcare sector. So this is also adding to expense as well. The events above that I've just described create a perfect storm for MA. No one is arguing MA will not grow because its value proposition will still dwarf traditional fee-for-service. But most large national plans, which is about over 3/4 of enrollment, as well as other plans, have seen their margins contract considerably over the past few years because of rising costs and lower revenues. And they see storm clouds on the horizon moving forward in MA. For 2025, many said they had to contract their geographies in the MA program, reduce benefits, and raise premiums. Humana and CVS Health are two large plans most concerned about the financial trends. They are the second and third largest enrollers of MA lives in the nation. Centene has struggled in MA for several years as well, and they have pretty large enrollment. Cigna is exiting, selling to Healthcare Service Corporation, so they're getting out of MA because of their struggles. Only United Healthcare and Elevance Health have been somewhat more bullish on their MA future, but there's also reason to believe that they could have cutbacks in benefits as well. For example, rumors are leaking out that in certain counties, United is actually restructuring its benefits as well, even though they plan on enrolling more people. So all of these costs and all of these lower revenues have led major plans, and we suspect other plans as well, to contract their benefits a bit, increase cost sharing, increase premiums in the MA program. And one big impact are those Inflation Reduction Act Part D changes that transfers costs to MA plans as well as the standalone PDPs. We don't know the magnitude of geographic contraction or benefit reductions or premium changes yet in MA. But again, by all accounts, these will be considerable. And this will have the effect of increasing costs and reducing choices for seniors. If plans exit geographies, it's possible that in certain areas of the country, the number of MA plans get reduced demonstrably, or we may even have total pullouts in these areas. But in fact, around the country, we do expect that benefit offerings will erode considerably across the board. And enrollees who are looking for the best deal will have increases in premiums pretty across the board, increased cost sharing, as well as fewer benefits. And again, those benefits are oftentimes supplemental benefits that aren't usually in Medicare fee-for-service, but those benefits too reduce the traditional cost sharing in Medicare fee-for-service to a lower level. So we'll see some of those things go away as well. The big problem is these will likely impact individuals with fixed incomes the most. So they'll feel the greatest impact for sure. With the MA potential October surprise and the benefit reductions there just discussed, we'll take our next break and we will dive deeper when we get back into the IRA changes causing the big issues and the potentially much larger impact on freestanding PDPs because of it.
Lilac Software is proud to work with the Healthcare Labyrinth website to educate people on the healthcare system. At Lilac, we believe transparency is so important in healthcare. The healthcare system is opaque, and Lilac is trying to bring clarity to data and unleash the best member care, reduce costs, and improve outcomes. Our cloud-native payer platform revolutionizes data insights and analytics. Plans have all the data they need, but in silos locked away in point solutions. At Lilac, we solve the data fragmentation problem and help plans turn complex data into actionable insights, leading to greater operating leverage, tight cost controls, and healthier members. Health plans can improve STAR scores, reduce medical expense, drive revenue, and more. Quite simply, with Lilac, you can drive better business and health outcomes. Learn more at lilacsoftware.com.
Welcome back, and we hope you're enjoying this episode. We've covered the MA potential benefit reductions and the October surprise. Now we'll talk a little more about the standalone PDP's potential October surprise and the IRA changes that are really contributing toward it. While the increase in costs in the Part D program clearly impacts both MAPDs and PDPs, the MAPDs are allowed to commingle Part C and Part D revenues from the government to fashion integrated benefits. The large revenue in Part C protects the smaller Part D benefit in MAPDs. In essence, they use a lot of dollars over on the Part D side to fashion the best benefit, and they're going to do a little of that even with these big IRA changes and the transfer of costs. So we will see overall reductions in MAPD across the board. The Part D benefit will probably not suffer as much. But standalone PDPs just don't have that luxury. They offer the retail drug benefit only. It is a small part of overall Medicare, and PDPs are unable to absorb the huge costs that are going to be transferred to it in the IRA. So therefore, major concerns are really emerging that standalone PDP plans will see skyrocketing premiums due to the unintended consequences of the major Part D restructuring and out-of-pocket cost reduction passed in the Inflation Reduction Act. Let's talk a little bit about those changes that passed as part of the Inflation Reduction Act and how dollars are being essentially transferred to the plans from other entities and essentially by capping out-of-pocket costs. So it's important to remember that the Inflation Reduction Act was passed in 22, and there have already been costs transferred over to plans through the Inflation Reduction Act, but the biggest amounts will be really coming in 2025. So in 2023, the cost of insulin was capped at no more than $35 per month. Now, the federal government didn't put more money on the table for that. They just told plans they had to cap the cost. And so therefore, the plans had to find ways to cap benefits in other ways. They either had to reduce benefits in other places or they had to raise premiums because there wasn't new money coming from the federal government. In 2024, the 5% cost sharing for members in the catastrophic phase was eliminated. And those costs also were largely borne by plans. And again, it was not underwritten by the federal government. So again, they had to cut benefits elsewhere or increase premiums. And I'll tell you in a little while that premiums have already gone up just because of those 23 and 24 changes. But let's talk about the major changes now coming in 25, the transfer of costs in the IRA to PDP plans and MAPD plans. Well, first you have the elimination of the coverage gap phase. There will no longer be a per drug 25% cost sharing for members. The initial phase essentially is extended into the catastrophic phase, and members will pay their initial phase copays or cost sharing in the benefit for brands and generics. Again, that 25% cost sharing was transferred from the member to, in part, the plan, so it's going to be adding to their costs. Costs in the catastrophic phase are moved from Medicare to plans and brand drug manufacturers. Medicare's direct costs will drop from 80% to 20% in the catastrophic phase, and plan responsibility will move from 15% to 60% in that phase. There will be a new 20% discount from brand drug makers in that phase. So you can see the lion's share of the costs of eliminating the cost in the catastrophic phase, moving them from Medicare to the plans and to the brand drug makers. Most of that cost is with health plans. This addresses rising reinsurance costs for Medicare, but the unintended consequence there is benefit reductions again and pretty marked premium increases because it's such a huge transfer. There is an offsetting change for plans. In the initial phase, brand drug makers have to give a 10% brand discount in addition to the rebates they negotiate with plans. Well, if they have to give an additional 10%, who knows if those rebates will stay consistent. But nonetheless, that theoretically is a savings for the plan there, a bit of an offset. Thus, the plan's obligations for brand costs drop to 65% from 75% in law today. Next, another major cost to plans is a new cap of $2,000 on out-of-pocket spending. Based on how the program works, with the elimination of the catastrophic cost sharing, a person in 2024 is currently capped at about $3,300. So plans will have to essentially underwrite another $1,300 in capped out-of-pocket spending. That's a significant reduction in out-of-pocket costs again in 25 and a major transfer of cost to plans. Members can also choose to enroll in a program with their Part D plan to spread their estimated monthly cost sharing over 12 months. It's not really a huge drug cost or anything like that because theoretically members are still paying those cost sharings, but it does amount to a significant administrative cost to plans and PBMs. In addition, PBMs are now required to pass certain price concessions on to pharmacies that were not necessarily passed through before. So all of these things amount to brand new costs for plans. So due in some measures to these changes in the IRA already in effect, standalone PDP average monthly enrollment weighted premiums were expected to jump 21.5% in 2024, just alone pretty much on those 23 insulin changes and the 24 5% cost sharing elimination in the catastrophic phase. So they were supposed to jump by about 21.5% in 24, from about $40 in 23 to about $48 a month in 24. Because existing members switched to and new members enrolled in lower premium plans, the actual enrollment weighted average was mitigated, that increase, to about $43 or about 5%. But for sure, what happened is people made sacrifices in terms of out-of-pocket costs in favor of lower premiums. When they went to a lower premium plan because the costs were too high for them, they knew they were going to have to pay higher out-of-pocket costs or frankly have some lower benefits. So just because that premium was mitigated from the expected increase from 40 to 48 instead to 40 to 43 doesn't mean that Americans will pay less. They'll have less benefits and perhaps higher out-of-pocket costs because of that in terms of cost-sharing deductibles and things like that. According to Avalier Health, about 45% of PDP enrollees face premium increase of more than 25% if they had not switched plans during that enrollment period. So about 45% probably made that change in 24 because of the major increase in premiums that were slated. Now, because of other major IRA changes coming in, as I just talked about in 25, estimates suggest that standalone PDP average monthly enrollment weighted premiums could go up between 50 and 100%, or perhaps even more, from 24 to 25. It is shocking, but it makes sense when you examine the new large items in the IRA that transfer costs to plans in 25 compared to what was happening in 23 and 24. Now, again, plan switching and new enrollment in lower premium plans could again reduce the projection, again, because enrollees will opt to lower monthly premiums but higher other costs throughout the year. So that is a potential huge increase, moving from $43 to $20-some if it's limited to 50% more per month, or as much as $40-some, or potentially the average premium could have increased to maybe about $100, which is just huge when you think about the fact that it was at about $40 on average in 2023. I would also note in 2024, PDP enrollees faced higher cost sharing for brand name drugs in general, as well as diminished plan choices and options because of all these IRA transferred costs. This will continue, I am sure, into 2025. In addition, plan offerings diminished as many private plans left or contracted offerings in given markets. Some estimates say choices for PDPs are at the lowest they have been since Part D launched in 2006. The number of available PDPs has decreased 25% since 2020. Also, premium-free Part D standalone drug plans for low-income subsidy-eligible beneficiaries, the very low income, decreased 34% from 2023, and only 20% of plans now offer a $0 premium for these poorest of the poor in the Medicare Part D program. So huge fallout and huge potential premium increases in 25. CMS tries to argue that all will be fine because the IRA had a new premium stabilization subsidy that caps the base premium amount to no more than a 6% increase per year from 2024 to 2029. So they argue in 25, base premiums will only go up by a couple of dollars. But again, this is based on the standard Part D benefit. Part D plans have always enhanced beyond the standard benefit, and enrollees have benefited from that. And the plans, because of all the IRA changes, will be on the hook for additional costs due to the transfer of liability to the plans from the government and out-of-pocket costs. So all these enhanced benefits above that base premium amount will have to be funded by higher premiums or have major cutbacks because of the transfer of the liability in the IRA to the plans. So that's just the reality of it. The way that the government and Congress set up the cap and the premium stabilization was just on the basic premium amount, which was the standard benefit. And we know that that is not how the Part D operates at this point, because there are so many benefit enhancements that are now at threat of going away. So with that, we'll take our third break here, and we'll come back and tell you about the fallout and what's our lessons learned here.
Health plans and insurance are confusing. Our healthcare system is in dire need of reform. Health policy expert Marc Ryan tackles both issues in his book, The Healthcare Labyrinth. It is both a guide to navigating health plans and fixing American health insurance. Marc dives deep into how health plans and the American health insurance system operate. He then outlines a comprehensive reform agenda for the system as a whole, including pricing, emphasizing health and care management, and ensuring affordable access to health coverage in a private delivery model. Marc is a bit of an unconventional Republican in that he believes affordable access is the morally right thing to do, and that it is also fiscally prudent for our nation. Learn more about Marc's book, The Healthcare Labyrinth, at healthcarelabyrinth.com or search at leading bookseller websites. Available in print, ebook, and audiobook forms.
Welcome back, and we hope you're enjoying this episode of the Healthcare Labyrinth Podcast. So we promised to sort of go into the possible fallout now of this potential October surprise for both MA and Part D. Well, the real impact will be felt as the enrollment season rolls out in October. Beginning October 1 with the 2025 plans going live on the Medicare Plan Finder, some 57 million Medicare enrollees will be grappling with fewer plan choices, higher premiums, and diminished benefits in both MA and standalone PDPs. Given complexity of enrollment in the Medicare world, it's also true that many children and friends of the elderly and disabled assist them in Medicare plan decisions each year. If just one non-Medicare eligible American helps each of the 57 million Medicare enrollees, that's at least 114 million Americans that suddenly become aware of huge cost increases in Medicare, Medicare Advantage, and standalone PDPs for everyday Americans. This is about 45% of the voting age population, and this is the potential October surprise I've been talking about. Well, CMS began realizing that they may have a problem here. They could not ameliorate the MA benefit cuts and premium increases, but they are trying to step in to fix the massive increases in PDP premiums that are slated. On July 29th, CMS released preliminary technical Medicare Part D bid information for contract year 25. The Part D base beneficiary premium, as expected, was capped at 6% growth in 2025, which amounts to just a few dollars, due to a stabilization fund set up in the Inflation Reduction Act, as I talked about. Again, this was because of all the transfers of cost to plans from the government and the caps on out-of-pocket costs in the IRA. The anticipated enrollment weighted average premiums, though, were not released, in part because CMS has now proposed to create an additional voluntary premium stabilization demonstration program, which is above and beyond the one in the IRA for standalone Part D PDP plans only. The program would reduce the base premium by $15. There would be a year-over-year increase limit in the premium of $35, which would be imposed on a plan's total Part D premium, which gets to the enhancement we talked about earlier, and a risk sharing with the government will be enhanced, with the government taking on some more risk. We don't know exactly who will participate among the standalone PDP plans and how much the premium hikes will be mitigated, but many plans are likely to take advantage. So there will be probable mitigation of PDP premiums, but not probably all of the increase will go away. The potential premium hikes for Medicare enrollees are a huge problem for sure. I feel for seniors. And CMS also has some broad demonstration authority under statute. But the proposal does not seem to fit the normal parameters for a demonstration. CMS says it is, quote, testing whether additional premium stabilization and revised risk corridors for standalone prescription drug plans increase the efficiency and economy of services, end quote. But I'm not convinced this is anything other than a massive additional subsidy to PDPs to deal with the unintended consequences of the IRA changes that the Biden administration and Democrats desperately wanted to pass. So what's the lesson here? Public policy changes always have unintended consequences. Many champion the passage of the IRA changes to Part D without really understanding the fallout. It sounded really good, and that's why some people hopped on the bandwagon. But any times benefits change or cost sharing is reduced, it stands to reason that a plan will need to increase premiums to offset the higher costs, especially if they're not funded by the government. Of course, policymakers and lawmakers will blame it all on the greedy insurance companies if these standalone PDP premium hikes still are pretty substantial. But the truth are, they are to blame. They designed the IRA and they passed the IRA. They did not fund the out-of-pocket reductions through government appropriations, and they transferred a great deal of cost from the government to plans. And thus, they levied the cost on people in the form of higher premiums. There will still be some winners with all these changes, even with higher premiums, whatever they end up being after the additional demonstration program. Those with high drug costs benefit from cost-sharing reductions, eliminations, and caps. But the truth is, everyone will be hurt by mammoth increases in premiums. Those on fixed income cannot afford this. While there are benefits to some, for sure the sickest, the vast majority could have huge affordability issues. Some could drop coverage while others could move from fee-for-service to MAPD and accelerate growth in that program. But when people leave the fee-for-service program for the MA program, that means there are fewer people in the fee-for-service program and the standalone PDPs, and they are sicker. That could send premiums up even more as adverse selection sets in the future. In the end, the IRA Part D changes were too good to be true. They were not financed by the government, and the costs were placed on plans and enrollees. This was entirely predictable. So the Democrats' October healthcare surprise, created in great measure by themselves, whether through simply running government or a lack of looking down the political road, so to speak, could have huge impact on them in the election. The MA surprise will be there for sure. The new premium stabilization program announced by CMS, probably outside of its regulatory authority, could mitigate some but not all of the PDP impacts. So some October PDP surprise will be there as well. We shall see the fallout in just a few short months. With that, we'll end this edition of the Healthcare Labyrinth Podcast, and we'll see you next time. Take care.
Thanks for joining Mark and the Healthcare Labyrinth Podcast. Go to healthcarelabyrinth.com each day for the latest healthcare news. See you next week on the next Healthcare Labyrinth Podcast.